Honorable guests, ladies and gentlemen, I'm Maggie. I'm a project manager from Ali House. I'm the host of this webinar today. Thank you for coming. Alibaba House, together with Jack Ma Foundation, Alibaba Foundation, is greatly honored to organize today's webinar with close to 70 medical experts from Rwanda and Cerebral Shaw hospitals as part of our global medic exchange for combating COVID-19 program, known as GMCC. The program aims to specific medical orders, as well as provide necessary communication channels to share practical experience of fighting COVID-19 frontline medical teams and around the world. So today, we are pleased to have Rwandan government officials and close to 7.
Good afternoon, colleagues in China. We are very pleased to be here with you. I'm with different colleagues here at the Ministry of Health. I'm with my colleague, Minister of State, in charge of public health, primary health care. I'm here with colleagues at Rwanda Biomedical Center, but they are located in their different location where they are watching this video conference. I'm here with other colleagues also at the central level. But we are with many colleagues at district hospitals because we have more than 43 district hospitals. The Director General of those hospitals are watching this video conference because they are part of the efforts to contain COVID-19. So it is a great pleasure to be with you this morning. And I would like to thank our President Paul Kagame for his leadership and strong cooperation with Jack Ma Foundation. And I thank also the CEO of RDB, who is supporting us in all interaction with the foundation, Jack Ma. I want to thank Dr. Chai, the president of Run How Hospital, Alibaba Health, and Jack Ma Foundation for arranging discussion of this morning on our side and this afternoon on your side. I thank colleagues at the Ministry of Health who participated in preparing this video conference as well. So we are very glad to hear from valuable China experience in medical community, especially for containing COVID-19. We want to learn a lot from your experience. We want to learn how you managed to control the outbreak, especially in Wuhan. We want to learn how you managed to increase your capacity of testing people who were at risk of being infected, how you traced contact of those people confirmed with COVID, and how you increase your capacity for quarantine, for isolating people who were infected and those who are suspected to be infected. We want to hear from you, your experience in how you manage the treatment centers, because we know how the workload is hard for human resources, for health personnel, how you manage to increase, especially the number of health personnel, to treat huge number of people who were infected, and how you contain the risk of having health staff infected by this disease. We want to hear from you because we are with 134 patients, 134 confirmed COVID cases, but recently we discharged 49, and we remain with 85 patients in our 2 treatment centers. But we have more than 500 people in isolation site as suspected contact or suspected people who were in contact with confirmed cases. So I think that we will learn a lot from your experience, and we want to learn if, in terms of treatment, if you try any antiviral treatment or any clinical trial you conducted during this experience, and even if you tested some candidate vaccine as you are treating, as you are facing this COVID-19 issue. I think today, the cooperation to contain COVID-19, it's not a choice, it's a must if we want really to solve this global challenge. And we are happy to learn from you and to share with you our experience as well. And we hope that with the innovation that the foundation of Alibaba is offering to us, especially in terms of a new platform to connect and share information, we learn a lot. We want also to hear your experience in using technology for tracing contact and containing suspect people in isolation place, like self-containing people. People can self-contain themselves, but if you use technology to keep them in a place so that they can't move and contaminate other people. And finally, your experience in using robots for case management. We watched it on TV, where you were using robots to deliver drugs or deliver foods to patients in China hospitals. If this can be also useful to us, if it happened that we need those robots for treating our patients. To end, I want to thank everybody who is participating in this video conference. We have some scientists on our side who will be happy to learn from their colleagues scientists who were involved in the containing COVID-19. So I wish to thank everybody, and we are ready to hear from your side and share our experience as well. Thank you so much.
Thank you.
Maybe from our Sarawak Hospital part. Good afternoon and good evening, everyone. It's very nice to see you through this special way. I'm Elaine from Center for International Collaboration of Sarawak Hospital. First of all, please allow me to introduce our experts team to you. So Dr. Cai Shoujun, the President of Sarawak Hospital. Ms. Zhuang Yiyu, the Vice President of Sarawak Hospital. Dr. Chen Wenjun, Director of the Medical Affairs Department. Dr. Pan Honghan, Director of the Critical Care Medicine Department. And Dr. Ge Huiqing, Director of the Respiratory Care Department. So we also invite another experts from the front line to attend these meetings. So we hope that today's section will set a foundation for further exchange between the medical experts from both countries, so that we may win the global fight against the coronavirus together. So next, I would like to invite our President, Dr. Cai Shoujun, to deliver some opening remarks. Thank you, Dr. Cai.
Dear Dr. Daniel, and dear distinguished leaders, guests, hospital managers, and medical workers from Rwanda. Good morning and good afternoon. I'm Dr. Cai Shoujun, surgeon for the abdominal surgery, also the president of Sarawak Hospital in China. It's a great pleasure and honor for me to meet with you on this special occasion. I've heard about that the first COVID-19 patient in Rwanda appeared on March 14. And 1 month later, today, a total of 27 cases was diagnosed in Rwanda. Definitely, this virus is spreading worldwide. Person enables threat to life and health, and brings a formidable challenge to the global public health, which calls for our unified action and deep collaboration. Currently, under the wise leadership of the Communist Party of China, as well as the tremendous endeavors which are made by the government and the medical care provided and every fellow citizen, the situation now in China is getting much better. Life and work are quickly returning to normal. As a public hospital in China, apart from the managing our hospital to keep it functioning during this period, We also dispatched 189 medical and nursing specialists to Wuhan and Jinmen in Hubei province. Today, they all come back home safe and sound. And some of them will meet with you in Q&A session. We hope our practice and experience could be valuable and helpful for you, and could be instruct in reduce affected cases in your country. I believe with our joint effort, we can defeat this war in the very near future. Good luck for China and for Rwanda. Thank you very much.
Thank you very much. Now let's welcome Dr. Chen Wenjun, the Director of Medical Affairs Department, to share our hospital's experience and working against the coronavirus. Thank you.
Dear friends from Africa and colleagues, I'm the Director of the Medical Affairs Department. I'm Dr. Chen. I'm also a surgeon of the oncological surgeon. Today, I will share the long experience against COVID-19. The topic is prevention and treatment system against COVID by the whole process management and innovation. Next slide. So today I will introduce 5 parts. The first, I will introduce overview of the campaign against virus in Seoul Hospital. The second, I will introduce the early stage of the epidemic. The prepare for action is very important. And the third one, when we into the outbreak periods, the first level response to the major public health emergency is very important. And after the outbreak period, there will be the post-pandemic periods. So the restoration and the precaution is same important. So we will win 2 battles to beat the virus, and we will win the recovery. Finally, I will simply introduce the management of severe and the critical patients. So my colleagues from the frontline teams, they will be more experienced. They will introduce them this content in detail. So first, I will introduce the overviews of campaign. From January 14th to the March 19th, there were 4,659 patients come to our hospital, the fever clinic. Among them, there were 328 patients was suspicious carrier. They were isolated in the quarantine wards. Finally, 9 cases were diagnosed, and 1,350 samples have been tested. We found 9 positive cases. But I will remind, we could not neglect the negative result. We should diagnose combined the main features of the CT scan and the clinical manifestations. They'll be more important because we have met the case. The 5 times tests were negative. The final test, the 6 times was positive. In our hospital, there are 16,860 staff engaged in the front line. And there were 16,075 patients will be admitted in the hospitalizations. And during about 2 months, there were 2,641 surgical procedures have been done. And there were no deaths and no hospital infections in our hospital. So we can create the miracle, and I think the first stage is very important. In Chinese saying, the good start is a half of success. So the early stage is important because we should prepare for action. When we get the information for the coronary virus pneumonia, and we should do the unified command. So firstly, we should set up the groups, 2 special groups for the COVID-19 infections. The first coordination meeting for prevention and control training was held on the January 4th this year. The unified command is most important, I think. So the leading group is very important. They can command all the procedure in our hospital. The experts and the rescue team for the patients. And the working group. The duty of working group is coordination and deployment, the staff and the submissions. Our staff, we should make the early emergency response plan and workflows. On the first hospital's level, the plans for the acute infection disease and the prevention of control COVID-19 infections, and also we make a plan for the surgical procedure, especially for the emergency operation procedure during the period of COVID-19 epidemic period. It's very important. And inpatient wards during the epidemic period, we should plan. The workflows, I mean the standardized workflows for the fever clinic and quarantine wards is important. We should do the standardized flow. And there were lots of guidelines for the quarantine wards, remodeling, and we set up the guidelines for the clinical sampling. We have made, in my memory, I think we have made at least 5 versions for the sampling. We make a guideline for sampling and for transport sample and test sample and report sample. In the department level, the public region is always high risk, I think. So we should do the plan for them to prevent contamination. Just like the public region, the radiology, ultrasound, EKG department also was including the DSA room and nuclear medicine department. So they have their individual plan to prevent contaminations. Some patients with high risk, just like the patient will accept the hemodialysis, or some patient will accept the endoscopic examinations. So we will make some plan for them. On the start of the COVID-19 preventions, I think every medical staff should be mobilized and be trained. The training for the physicians, nurses, and the rescue team is important. Up now, there were 7 additions for the guidelines that COVID-19 infections have been published in China. So in our hospitals, the mandatory online tests for each medical staff have been done. The hardware preparation for granting I think, is maybe the most important steps for preventations. Usually, most of the hospitals say their space for the isolation maybe is not enough for the epidemic periods. So we should remodel them. In our hospital, 4 units were remodeled for quarantine of suspected patients, and 2 units were remodeled as fever clinic. And 1 negative pressure room in ICU was prepared for severe or critical cases of suspected patients. An emergency quarantine room in each inpatient floor was prepared, because we cannot prepare. Promise there was no fever patients in every floor, so we should prepare the emergency isolate room. The transferring system is important. The purpose of our work is to decrease contamination as possible as we can. So the medical transporting system was set up, including the transportation for the confirmed cases was set up. And a COVID-19 alert and report system has been set up. We have the special crisis variant report system, including the reported test of the nuclear virus, and also the report for the CT scan. If the physicians or radiologists have found the typical manufacturer change in chest CT scan, they will report the physician and related staffs as quick as they can. So the fever clinic, I think, is the gate of the COVID-19 control. Just like I said, the good start is the half of success. So when we control the fever clinic, and we can, it means we have get the half success. Otherwise, maybe the failure will be coming. So the clearance signs is very important. From the entrance of our hospital to the nurse station of the fever clinic, there were clear signs on the road. And the 3 zones must be shared in the clinic, the fever clinic regions: the clear zone and the potential contaminated zone, and the contaminated zone, with the different colors on floor. There is a special road. It means a designated road from the fever clinic to the radiology road, because this road maybe will be contaminated with other persons in the hospitals. So how to control the fever, the patients with fever? In this chat, we just introduced the second evaluations, but now I think we have did the third evaluations, because we have put forward the first evaluation, I mean the initial assessment on our the web line. So when the patient come to our hospital, it means the second evaluations for the clinic and emergencies, just like the fever and the respiratory syndromes. And we will ask some patients the history, the related history So we will check the patient or the person, the accompanied person with a mask. When the patients and accompany come to the nursing station, so we will do the second evaluations. If the patient have the epidemic history, so these patients will be carried to the isolation room, and the doctor will ask the history and the physical examination in detail. The quick blood test and the flow test for distinguish the diagnosis will be done. And in some cases, if we suspicious we consider it maybe suspicious the COVID-19 infections, the chest CT scan will be done. Otherwise, if the patient without any epidemic history, so we will be these patients will be treated in the normal process. So according to the standardizing of guideline of COVID-19, the suspected cases will be considered. The expert consultation will be performed, and COVID-19 nucleic acid test will be done for next step. If the test was positive, this patient will be carried into the isolation wards. So in the whole procedure, the contamination should be decreased as we can, as possible as we can. When we got into the outbreak period, I think the first level response to the major public health emergency is important. Sir Hospital have some innovations. We will upgrade the prevention and control procedures on our hospitals continuously, and standardize the process to take care of the patients from the entrance to ward will be fixed. And we also use internet and medical service, both line, and a solid artificial intelligence epidemic prevention system will be used. And we have integrated medical resource with front lines. So every patient have his individual stage. We upgrade the prevention and control efforts in our hospital continuously. From the screen points, the temperature and the epidemiologic history and screening at the main entrance gate. Every person coming in our hospital will be done. Now we just use a health QR code. It's very useful and very convenient. This code is based on the online epidemiological questionnaires and the big data, including the real-time public data and the social credit system, such as travel, medical records, and epidemiological histories. The red code, it means this patient will be carried to the fever clinic. The yellow code will be go to the special outpatients area. We call it the yellow area. The green, it means the normal outpatients areas. So different color means that different ways, different procedure. We upgrade the prevention and control efforts. I just introduced the admission procedure first. When the epidemic periods, there were less patients coming hospitals. So we just selected some patients just for the limited procedure, just like the limited operation or limited just a therapy, just like the chemo. And we will promise the emergency patients' needs. So we mean how selective admissions. The second, we reconfirm the epidemiological history and health codes, just I talked just before. For every patient, before he is admitted, the chest CT scan will be done before admissions. Because in our experience, the CT scan can afford more informations. And the fixed room and fix the floor for this signed physicians was set up, and informed consent for the strict hospitalization laws will be set up during the epidemic. We should prevent the companies of patients. So the nursing department designed the purple wristband for them. And we see the patient's wristband is white. The company is purple. So we can distinguish. In Novartis AI epidemic prevention system at Solana Hospital, we have several parts. One is online promotion or educations. We have published 6 articles about this epidemic, and we tell the public people. And we have organized 19 online lectures on epidemic preventions. We let more people to know knowledge about this pneumonia. And we also broadcasted 14 live sessions on psychological adversary. We advocate not the mask on our mouth, also the mask on our hearts, the psychologist mask. And the remote inquiry or consultations is very needed, because the anxiety or fear from the people will be coming in on the epidemic periods. So the Solana Hospital is the earliest hospital to do the remote inquiry or consultations. And just I said, we did the online AI self-test for COVID-19. It's very convenient and very useful, and we can decrease the contamination as possible as it can. Do this test only needs 10 seconds, so the patient can know what's the risk, what's the level of risk. And online prescriptions and follow-up system for chronic disease have been done in our hospital, because except for the COVID-19 patients, there are lots of the patients with chronic disease. They need the continuous therapy, and they need the medicines. So our hospital gives them the medicines to their house or their apartment, just like the Christmas grandpa. And we did integrate medical resource with frontline. For the difficult case, or especially for the critical patients, they need MDT. So individuals in therapy for every cases, just like I said, the one stage for one patient is important because the condition of the different patient will be different prognosis. There were several innovative tips for preventing hospital infections. So Longshore Hospital innovative the TSMS, it means the temperature symptoms monitoring systems for the staff with fever and with respiratory syndromes. We report this chart every day. And we changed the dining styles. We just called is college in Chinese test dials for the staffs and for patients. The daily COVID-19 preventions and control quality checklist from each staff. And we also did the meal delivery lobby in quality wards. It's changed the work sites, work styles. All the meetings of the academic activities will be went online modes. On post-pandemic periods, the restoration and the precaution is same important. So this is a chat for our hospitals. We can see the increase of procedures in recent 10 days. So now we have maybe recovered more than 80% of the usual work. We also help the local business, let them the factory or the business to recover their normal work with Sir Longshaw's hospitals instruction and guidelines. And last, I will introduce the management of severe and critical patients. This experience from the frontline teams. And so Longshore Hospital just dispatched our staff. The total numbers is 189, and more than 140 again to the Hubei province. This is most severe conditions in China. They did a very great work, and when they came to the Hubei province, there were more than about 10 patients. They used ECMO, but at last, the 72 patients discharged, including the 37 critical cases and the 28 severe cases. So how to manage the severe and critical patients is very important. We should, according to the characteristics of the severe respiratory features and how to manage the ventilation support recommendations, I think my colleagues will be introduced in detail later. So I think the virus is cold, but the hearts of our hearts is warm. The virus has been beyond borders, and our collaboration is as well be helpful. So I think we should the firm belief and the scientific preventations and the precise stage is important to prevent or control the COVID-19. Thank you.
Now we're going to another session, QA session. We would like to invite the Longshore Hospital experts to start our joint QA session. We have collected several questions, emails in advance from the doctor and the hospitals in Rwanda. Now we are going to go through a few of the main ones before opening our call to the leading questions from Rwanda. Now, it's like a session. Okay. First question, I would like to ask our Dr. Zhao Dongdong to answer this question.
The question is how to organize screening in order to detect any suspect case. As mentioned, that any patient who comes to our hospital will be checked in the main entrance. We will check the epidemiological history and we will check the temperature of the patient. If the patient is febrile, or if we can see a positive epidemiological history, like he or she has traveled in epidemic area, has been contacted with confirmed cases, and will be sent to the fever clinic. And in the fever clinic, we will order a lot of tests, like blood tests, CBC, most important, CAT scan. We will determine from the results of the if the patient is a viral infection.
Can I ask the questions before he leaves?
Yeah, sure. Thank you for the presentation, Dr. Chai. Thank you for the presentation. We learned a lot in your presentation, but I have 3 questions. We want to know how you are managing the risk of resurgence, because we hear that you have now some imported cases arriving in the country. How do you manage borders to avoid the entrance of imported cases? That is the first question. The second one, the use of rapid tests. What is your experience in using rapid tests in the management of COVID-19? Can you share with us your experience in using COVID rapid tests? The last one, the last one, it's which type of antiviral treatment are you using for treating the case? Which type of antiviral treatment are you using? Thank you.
All the confirmed cases was sent to the designated hospital for treatment. So for those came back from foreign countries will be isolated for at least 2 weeks, for 2 weeks, which is required by the government. Does that answer your question?
Yes, for the third one.
Okay.
Second question.
Second question is, what is your experience with the use of rapid tests? 就是测试的那个 testing kit, rapid testing kit. 你们的那个经验是什么？
Usually will take 4 hours to give the report.
所以现在贵医院现在用的是怎么样？是什么测试
RT-PCR. Nucleic acid test is a main test for diagnosis of COVID-19. But we also did the rapid test for the blood the antibody of the COVID-19. But this is just informed the more information. But we can't diagnose the COVID depend only on the antibody. We should combine the other factors. The final diagnosis should depend on the nucleic acid test.
Yes, okay. And then I think the third, if that answers your question, I think the third question is, what sort of antiviral treatment has the hospital used in the treatment of COVID-19 patients?
Dr. Zhou Yong will answer this question.
So we use Kovat and Antiviral at early stage of the COVID-19 patients.
And which one? The second one?
What?
The second one. Caletra is fine. The second one.
Abidor,
能重复一下？对。
Kalicha
never-
and Abidor.
Culture.
You didn't try hydrochloroquine and azithromycin? No.
No.
Okay. Okay. Thank you. Yeah.
So thank you for answer to Honorable Minister. Then we can resume with the question and answers, and you can guide us. Is it clear?
Thank you very much, Honorable Minister. So I think we can continue with the other questions now. 我们可以继续回答其他问题了，因为部长他可能等一下要走了。
Okay, the first question. As Dr. Chen has mentioned that we will do the check on the main entrance for every patient comes to our hospital. We will check the epidemiological history and we will check the temperature. If the patient is febrile, or we can see positive epidemiological history, like he or she has been to an epidemic area or has contacted with a confirmed case, then the patient will be sent to the fever clinic. In the fever clinic, we will order some tests, the blood test, CBC, CRP, and also the most important, we will do a chest CT scan. We should determine if the patient is a viral infection because the SARS-CoV-2 is a viral. And if we find out typical manifestations from the CT scan, and certainly the patient will determine as a suspect case. That's for the question.
Now, okay, we will invite Dr. Zhou Yong to answer the second question.
So my answer is we recommended triage policy for COVID-19, considering the shortage of hospital capacity caused by the surge. For mild patients, isolation in Fangchang Hospital or at home is effective. They need observation and early antiviral therapy. Chinese herbs might help. Severe or critically ill patients should be hospitalized. Some may need ICU service. Oxygen inhalation and supportive therapy is the key in those patients. Once indicated, early intubation and ECMO are recommended. Others are conservative through thrombosis, prophylaxis, nutrition support. Some may need a short-term low-dose steroid, reduce days of invasive mechanical ventilation once it is not required. NIV should be used for other indications, such as chronic pulmonary disease. Convalescent plasma might be useful in selective patients. Thank you.
Okay, thank you, Dr. Zhou. Now we will ask Dr. Dao Jing to answer the third question. Thank you. Please, Dr. Dao.
Okay, I'll answer the third question. So the first is a very important thing. Facilities should have policies and procedures describing a recommended sequence for safely donning and removing PPE. The procedure to don and doff should be tailored to the specific type of PPE that you have available at your facility. Healthcare workers must receive comprehensive training and examination on PPE, such as when and what PPE is necessary, how to don and doff PPE step by step, limitations of PPE. Also, PPE must be done in clean area before entering the patient area. and removed in semi-contaminated area. When caring for patients with confirmed or suspected COVID-19, PPE must be used. After putting all the PPE, no skin or inner clothing should be exposed, and you should move your arms, legs, bend down, and squat to check the fitness of PPE. PPE must remain in place for the duration of work in potential contaminated area. It must be removed slowly in a sequence that prevents self-contamination and ensure to others without PPE are around. Also, perform hand hygiene is very important when you remove the PPE. A treated observer using a checklist is recommended to facilitate and check the sequence of steps in putting on or removing PPE. A video of flowchart of the procedure for donning and doffing PPE is recommended in the proper area. Disposal of PPE should be treated as a medical waste, following the local policies. Waste generated in the care of patients with confirmed or suspected COVID-19 should be sealed and labeled, do not contaminate the environment. Thank you.
Thank you, Dr. Zhao. Now the question will be related with the nursing. Now we would like to invite Ms. Zhang Yi, our Vice President of Surrounding Hospital, to answer this question. Thank you.
Hi. Regarding nursing management, I have 6 successful strategies that I would like to share with you. First is the very good leadership. The multidisciplinary cooperation is the key. The second is our hospital allocated special areas for fever clinic, as Dr. Chen mentioned before, and we have isolation rooms. We created 4 nursing units for the isolation wards. And the third strategy is the intensive training for nursing staff. We train all the nursing staff the proper use of PPE, and to make we have a lot of trainings and updated knowledge sharing with the nursing staff. The fourth strategy is we cleared enough space for admitting suspected cases in order to have enough room for those patients to isolate from other patients, inpatients. And the fifth is the QA check, the quality assurance check. Together with work with the infection control department, we develop several checklists to make the quality assurance. The last thing is the sixth strategy is the staff safety management protocol. There's 8 nursing units were cleared for staff who off the duty from the fever clinic and isolation rooms. These areas are restricted areas, 1 room for 1 person, and the dedicated person are responsible for ensuring the needs of the staff and monitoring the health condition for our working staff. An isolation policy for staff came back from the epidemic area and self-monitoring health condition system, which is very effective to prevent the possibility of the virus transmission. That's the experience that I can share with you. Thank you.
Thank you. Thank you very much. Now, turn to this question. I would like to ask our Dr. Pan to answer this question. Thank you.
Hi, good morning and good afternoon, everyone. I'm Dr. Pan. I'm from ICU doctor. I just came back from Wuhan working. Now I answered following 2 questions. I think number 5 and number 6 questions are complicated. So I tried in a limited time answer these 2 questions. First question, about there is a best treatment. I think the no best treatment approach to reduce ventilator in clinic patients. I think we can try our best, maybe can reduce this needs. So I propose a bundle for early, just like this screening, treasure, monitor, and support. So we can do early diagnosis, early classification, severity, early intervention, and early oxygen therapy. But we must be cautious. Don't give too much fluid, and fluid overload can worsen oxygenation. Question 2, it's more complicated. We know oxygen delivery are related oxygen partial pressure, hemoglobin, and cardiac output. So we can try a treatment in a clinic to promotion or increase PO2 concentration, hemoglobin concentration, and increase cardiac output, maybe increase heart rate, increase heart contractility, so we can promote DO2. About cytokine inflammatory cascade and lung liver damage is more complicated. We know we can classify 2 phases of responses. Primary inflammatory responses is happening early after viral infection, before appearance of neutralizing antibodies. So by ways of apoptosis, pyroptosis, ACE downregulation, ACE2 shedding, this with mechanism can cause cytokine release, expression of antiviral factors, and at lastly can cause pulmonary cell infiltration and pulmonary or lung injury. And second inflammatory response is about complex of virus antibodies. It can cause FCR activation, complement system activation, and maybe ADCC involved in this mechanism. So lastly, this can induce the acute lung injury, cellular damages. And about liver damage, some articles showed a lot of results, present a liver enzyme examination increased. So maybe these are possible contributing factors. First, cytotoxic T cells and induction of dysregulated innate immune response. Second, myositis. 3, hypoxic hepatitis and drug-induced liver injury. Lastly, mechanical ventilation may cause liver damage. Thank you.
Thank you, Dr. Pan. So Dr. Pan will have already answered the 2 questions, 5th and 6th. Thank you very much. Now we want to invite Dr. Zhou Yong to answer the 7th question.
So the most common complication of the COVID-19 is ARDS. So it usually takes 8 to 10 days from symptom initiation to ARDS. And the mortality of intubated patients is about 30 to 60%. For ECMO patients, the mortality can be as high as more than 80. Thank you.
Thank you very much. Now we will ask Dr. Zhao Jing to answer the 8th question.
For the eighth question, it depends on working conditions such as the temperature and the personal physical conditions. Normally, we change the PPE every 4 hours. But if you're feeling uncomfortable, such as shortness of breath or PPE is contaminated, it should be removed immediately. Thank you.
Okay, sorry, the next question, the answer, now she is not available. So probably we will just like, now we'll open up for the question from the participants on call. Could we please ask all the participants to identify themselves by names and their hospitals? Oh, sorry, Dr. Ge Huiqing is coming.
Oh.
So she will answer the final questions. Next question.
Okay, thank you. The final question is about the treatment modalities. I think the treatment modalities was largely supportive. It's including the ventilator support, early oxygen support is recommended, and NIV and high flow maybe for selected patients. And the early intubation is our recommendation. That's for prevent the lung protective lung injury, continued lung injury. So the other thing I think the doctors, Dr. Zhou maybe already answered the questions. Thank you.
Thank you. Thank you very much, Dr. Ge. Now we are just like going to go through the open up questions. So as I mentioned before, please click the raise your hand icon on your screen and or take your questions in the public comments area. Now we're going to the free talk. Any questions?
Yes, I think there are some questions that have been coming in through the Q&A as well. So until I think I've just told all participants you can use the raise your hand function and we can open the mic up in turn to you. In the meantime, I think we have a first question that we've taken in from the chat, and it says that it seems that CT scans are used first for suspected cases. Is that right? Or are the testing kits used first? Are CT scans done for all patients who are suspected of COVID-19?
Yes, we did CT scan for all COVID-19 patients. In ICU, we were doing it every 3 to 5 days.
Thank you. And there's a second question. When do you use corticosteroids? Do you use them for patients with mild respiratory problems or for critical patients? 就什么时候会用体质类固醇？
For those with mild respiratory signs or for critical things.
Yeah, we didn't recommendation for steroid, but sometimes we can try. For example, in critical care, in critical patients, for with respiratory failure and O2 ratio is very low, and some patient with ECMO support, we can we do some try about the dosage. We recommend suggest the 1 to 4 milligram per kilo weight. And period, we suggested the 1 to 3 days, less than 5 days. Thank you.
We have another question from Dr. Mouvenyi. Bienvenue. What was the epidemiological history like in your hospital? In our country, we asked if there has been any recent travel to countries with high transmission rate outside of Rwanda or from Kigali as the epicenter of COVID-19 cases in Rwanda. 他们想问的就是说，在贵医院这里，就是说大部分病例是从哪里来的？是输入性的，然后会不会去问病人最近的这个旅游史等等？就大部分的病例是社区传染的，还是怎么来的？
The city is Hangzhou in Zhejiang province in China. It's not an academic area, so we do not have a lot of cases in Hangzhou. So most of the cases are actually related to like Wuhan. So we really pay attention to the epidemiological history. We will ask if the patient has been traveled to Wuhan or has come from the other countries and or has contact with other confirmed cases. And another thing, we will ask if there's multiple febrile patients in their family. If there's more than one, then we will suspect the patient as a suspected case, and we will do the test.
Thank you. We have another question from Dr. Tionese from Mimbizi Hospital. And he would like to get some advice on how to handle waste management in isolation rooms.
We treated all the waste in the isolation ward or isolation ICU as medical waste, and you should treat this kind of waste. Follow your policy, follow your local policy. In our hospital, we treated the medical waste. We should be sealed and labeled, and we will be sealed and labeled.
Excuse me, can we from what I can see, Phil Ivan has raised his hand, and you have doctors as well, like Dr. Etienne. So if you can reserve some priority to speakers or panelists from Rwanda, that would be nice. And you start one by one. You have the list of the panelists, and after that we can go to other attendees. So that is a question from Dr. Zuberi here in Rwanda. Thank you.
Use the raise the hand function and we can open the mic for you.
Can you repeat, please? Priority to Rwanda panelists. They are like,
right.
17.
Nicole.
So we can, for example,
we have 7 panelists.
Yes, we can start with Etienne, Menelas, Ivan, and so on.
Yeah.
Sure.
Probably
Professor
is around us.
Sure. Sure, no problem.
So,
thank you very much. Current progress in the vaccine development, but also on the pathogenesis of this disease. Have you been able to look at what are the virological correlates on disease progression? For instance, the impact of viral load to determine the severity of the disease. And the second question about vaccine development, which kind of immune responses, whether cellular or humoral immune responses, are being developed by those people who are infected by the SARS-CoV-2? And eventually, also, if these immune responses have an impact, correlate of disease progression. Thank you very much.
Thank you. Patrick, can we have an answer on that one and then we take the next one?
Yes, of course.
第一个是讲病毒，
知道吗？我没听懂他这个问题。
第一个是讲病毒的独立。
I think the scientists are still doing research whether patients have higher viral load will develop more critical illness. That's not for sure, but we suspect that. There are actually some research that told us if the patient with higher antibody, they actually are more severe than patients with lower level of antibody. So that's also a question for vaccine development. From other disease like dengue fever, we have seen this scenario like if a patient being infected with one type of dengue fever, then he or she will be more severe when he or she get another type of dengue fever. So maybe there's some similar situation in the SARS-CoV-2 infection. We call it antibody-dependent enhancement. We still don't know whether it's a confirmed situation, but we should pay attention to the antibody treatment and the vaccine development.
Dr. Emil, if you can hear me, please proceed and then ask your question.
I'm unmuting Dr. Emil. Hold on just a second. Okay.
Hello?
Are you here?
Not that good. So.
Okay.
Hello?
Hello.
Yes. Can you hear me?
I can hear you perfectly. What's your question, sir?
I'm Ivan Emir. I would like to just highlight 3 points, specifically on lab detection using the PCR protocol. As you heard from the Honorable Minister for Rwanda, we've been able to detect the first 137 samples, and all of them were confirmed COVID-19 positive. The current protocol we are using, we are looking for the N-gene and the open reading frame AB1, or using the DAN gene protocol. But also we are looking for the presence of the E gene and the RDRP gene to confirm the COVID presence. The key challenge we would like to raise in the presentation is that some of the genes we are looking for COVID-19 do not concord with the N gene and ORF, implying that the presence of DRP gene is one that is actually confirms the actual presence of true positive COVID-19 for all cases. We would like to learn from the Chinese community on what actually is the confirmatory marker for COVID-19 for those who are using the N gene and ORF-AB1. The other instances, do you usually encounter any laboratory test result that you would presumably term presumptive positive in case the protocols of the two genes do not concord in the laboratory? And the third one is, do you actually find that the so-called presumptive cases end up turning negative COVID-19 after a period of 14 days? This is for our case what we are trying to see for the samples returning to the lab for confirmation. The first one of a learning experience is that after 14 days of the first 2 positive PCR, the third PCR may surprisingly turn back to positive. And we are wondering whether this one is instances of reinfection or a new infection or a declined immunity. Of course, I cannot leave the talk without mentioning that the presence of IgG, IgM in a rapid test of so-called rapid test for COVID is still confusing and cannot be relied for screening COVID. But we're also finding it interesting phenomena where even people who are not COVID positive are positive for rapid test. Therefore, the rapid tests are still yet to be defined on where they can be useful in a resource setting, limited settings. We would like also to learn from the Chinese community in terms of laboratory detection of COVID, is there a shortest turnaround time for PCR detection of COVID? If there is any less than 2 hours, which one is it that we can learn from you so that we can speed up the return of results for patients under quarantine or who wish to be provided quick results in terms of emergence? The other question that I would like to have to pose is, do you recommend oropharyngeal swab rather than nasopharyngeal swab while collecting a COVID sample in case you want to catch a rich harvest of the virus? The other one is, we're also not sure what is the best sample you can capture for a cadaver of any suspect. We have been reading through several guidelines from World Health Organization, but we don't know whether if a sample from a suspected cadaver should be the same as for anybody who is asymptomatic or symptomatic using the nasal swab or oropharyngeal swab. That's a bit of my talk. I can open up for any question or responses for my curiosities. Thank you.
Because of the time limit limitation, so probably we will just like to select the several questions to answer.
Okay, I will try my best to answer some of your questions. The first one, which gene we test for SARS-CoV-2? Every country or every company, they develop different kits for the detection of SARS-CoV-2. We usually use 2 genes, ORF1AB and the M gene. There are some special situation when the patient, the results come only positive for 1 gene. Usually it's the N gene. When we treat the patients in the later phase, we may see that kind of situation. And the second question, we recommend nasopharyngeal swab more than throat swab, that's for sure. And sputum is much more convenient, and we can get a positive result more from the sputum sample. So actually, we recommend sputum as the first sample you can do the test. For another question, the patients become positive after 14 days of negative test. We don't think it's a reinfection. They are just shedding RNA. And there are some questions about the contagious of this kind of patients. There has been no cases of infection or transmitted from this kind of patients for now, as we know.
Thank you, Dr. Zhang.
Okay, thank you. To the extent that our participants in Rwanda have any more questions, we would like to refer you to the GMCC program website. That's covid/19.alibaba/inc.com and show on the screen. The website includes resources on managing COVID-19 and also features a national medical expert communication center where medical experts can discuss their latest experience in epidemic prevention and control. So once again, we'd like to thank you all our guests today for your valuable time, and we hope that was a meaningful and useful session for us all. We believe that we must share our resources, know-how, and hard-earned lessons to win the battle against COVID-19. So this is one work, one fight. Thank you all.
Thank you.